Assistant Professor in the Internal Medicine Department at the University of Kansas School of Medicine. He graduated from Kansas University in 2000 with a degree in Business Administration in 2005. Actually, 4 years later, he graduated from the University of Kansas School of Medicine. This evening, Dr. Kempke will speak on the subject of osteoporosis. Please welcome Dr. Kempke.
I'm going to adjust this a little here. Okay, well, hello everyone. Thanks everybody for coming. So as you just heard, I'm from Ellsworth originally. My wife is actually an original Hutchinsonian, so we've come back home here, and she's starting up with OBGYN and me with internal medicine and endocrinology, and we're very excited about that, so and happy to be here talking tonight. So I'm going to talk about osteoporosis, but I want to start a little bit talking about endocrinology. I just finished my fellowship up at University of Kansas in Kansas City, and this, as you just heard, this is kind of a new field, not overall, but a new specialty that we have here in Hutchinson. So I wanted to talk a little bit about that as well. So endocrinology is a 2-year fellowship that follows a 3-year internal medicine residency. It's a subspecialty of internal medicine that deals primarily with the diagnosis and treatment of conditions related to hormones. And primarily what we end up dealing with are diseases that are related to either the over or underproduction of certain hormones or tumors of hormone-producing glands. So a little bit more in detail about that. I'm going to go through just a few of the endocrine hormones and endocrine glands briefly, starting top to bottom. So the pituitary gland is a small gland located at the base of the brain behind the eyes. It produces more than that, but primarily 7 hormones of interest, and many of those go on to control hormone production in other glands. So we kind of think of the pituitary as the master gland. In addition to disorders of over or underproduction of those hormones, the pituitary can also develop tumors. So these are all problems that we help deal with. Next is the thyroid. This is a little bit more famous gland than the pituitary. It's a gland located at the base of the neck. It produces a hormone called thyroid hormone. We deal primarily with disorders of over or underproduction of this hormone. However, thyroid nodules are pretty common, and we also deal with thyroid cancer when that unfortunate circumstance arises. Next is the parathyroid glands. These are a little bit less famous than their next door neighbor, but they're 4 very small glands that live right behind the thyroid, which is where they get their name. They produce a hormone called parathyroid hormone, and their main job is to help control calcium levels in the body. And again, problems here can arise from over or underproduction of this hormone or tumors of the parathyroid glands. The adrenal glands are 2 glands that live on top of the kidneys. They produce several hormones. I've mentioned a few here, some of the more famous ones: cortisol, adrenaline, and there's actually several other very close cousins of adrenaline that it makes, and aldosterone. And I mentioned these ones specifically because any disorder that produces too much of these hormones can lead to high blood pressure in addition to some other problems. So I use that as an example to show kind of the scope of endocrinology and what other problems can arise from hormone problems. The pancreas is most famous for producing insulin, and either a lack of insulin, which would be like type 1 diabetes, or when the body becomes resistant to insulin and the pancreas can't make enough to keep up with those demands anymore, which would be like type 2 diabetes, is a major problem that endocrinologists deal with. So that's one of the major medical conditions that we help control. And then lastly, the ovaries and the testes make estrogen and testosterone respectively. So this is sort of running the gamut for the most part of endocrinology. And you may say, well, that's great, but I thought we were talking about osteoporosis in bones today, so what about that? Well, interestingly, with bones, there is a constant remodeling process going on. So if my pointer, it's maybe hard to see here, but basically there are cells that live on the surface of bones called osteoclasts that are constantly going through and removing some bone. And then there's cells that follow them called osteoblasts that put down new bone. Not unlike if you've driven on 30th Street in the last couple of days, not unlike the process going on there. So taking up the old stuff and putting down new stuff. And interestingly, there are several hormones that, to greater or lesser extents, play a role in how active that bone remodeling process is. So I've labeled those up here, if I can get my, I don't know if the pointer works too well, but up in the upper right-hand corner, thyroid hormone, parathyroid hormone, cortisol, some of these hormones we've already mentioned, vitamin D, estrogen, testosterone, all play a role in bone health. So that's why ultimately osteoporosis ends up kind of falling under the endocrinology realm. Okay, so with that introduction, I'm going to start talking a little bit more specifically about osteoporosis now. So we'll start with the definition. Osteoporosis is defined as a systemic skeletal disease that's characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. So basically what that means is the bones get weak and you have higher risk for having a fracture. And really it's that higher risk of fracture that we're concerned about. Is there, oh, let's try this. That's a little better. Okay, thank you. So, so ultimately, it's this higher risk of fracture that we're worried about, and we want to try to prevent. And if you can see here, just a microscopic picture of normal bone, which may not mean a lot to look at that, but if you compare it over to osteoporotic bone, it's not hard to imagine that this is much higher risk for having a fracture than this, right? Okay, so I chose the topic of osteoporosis to talk about. And it's important. So why is it important? Why did I pick this topic? Well, 3 reasons. It's common, it's serious, and luckily it's preventable and or treatable. So we're going to talk about all those things. So osteoporosis is common. A little bit more details about that. So a few statistics. It's the most common bone disease. In the United States, 10 million people have osteoporosis, and another 33 million people have what we call osteopenia, or low bone density. And worldwide, over 200 million people have osteoporosis, so it's a very common disease. Again, in the United States, 50% of Caucasian women and 20% of Caucasian men will experience an osteoporotic fracture, or a fracture that's because of osteoporosis in their life. So again, a pretty prevalent problem. Just to show this graphically, because sometimes that helps picture this a little bit more. This is all in females, but if you look at the number of new diagnoses of breast cancer in a year, stroke in a year, and heart attack in a year, all in females, all these are much less than having a fracture because of osteoporosis. And even if you add all 3 of these up, this is still almost twice as common. So again, very prevalent disease that's serious. Luckily, as I alluded to, this is a treatable disease. We're going to talk a little bit more specifically about treatment just a little bit later, but I wanted to show this because these are all various different studies that have all shown that multiple different medications that we have all decrease the risk for having fractures. So we can do something about this. That's another reason why it's important. If there's a disease that we know about but we have no treatment for, then it's like, well, you know, can't really do much about it. This is something we can do something about, so it's important. I don't look at this and pay much attention to the percentages. These aren't head-to-head studies, so one of these having a little bit higher percentage compared to a different medication doesn't mean much in this context, so I don't want anyone to get caught up about that. But the point is just that we have multiple different medications that can help osteoporosis. So we can treat it, we can prevent it. How do we diagnose it? To talk about diagnosis, we have to first, again, kind of review what osteoporosis is. When it comes down to it, it's basically a decrease in bone strength. Bone strength is really a combination of bone density and bone quality. Bone quality can be thought of a few different ways. It kind of includes different features like the architecture, the turnover rate of the bone, prior damage, and the extent of mineralization in the bone. these things, bone quality, is not really easy to measure. We don't really have a good way to assess that. Bone density, on the other hand, the other half of what makes up bone strength, we can measure. We have very reliable ways to measure that. So that's our best way to try to assess bone strength overall, although it's not a perfect test because we can't really assess bone quality very well. So how can we assess bone density? This is a schematic of a DEXA machine, or dual energy X-ray absorptiometry. And many of you, maybe this is the actual picture of the most recent GE brand of the DEXA machine. So a lot of you out here have probably had this done. It's basically an X-ray, although the amount of radiation that it uses compared to just a normal X-ray is much less. It's a pretty minimal amount of radiation exposure. What this machine does is gives us two numbers of note, really. It gives at several different sites, but it gives us an absolute bone density, and then more importantly, it gives us a number called a T-score, which is a comparison of the patient's bone density compared to a healthy young adult bone density. And that number, the T-score, is what we can use to help diagnose osteoporosis. So I'm going to backtrack just a second here. So we're talking about diagnosis of osteoporosis. The first way that you can diagnose osteoporosis, and the way we prefer not to diagnose it, is if someone has a fragility fracture. Fragility fracture means a fracture that has occurred from an amount of trauma that you would not expect to cause a fracture. And the classic example we use for this is a fracture that occurred from a fall from standing height. So the idea is that a fall from standing height, meaning you're walking through your house and trip and fall and catch yourself with your wrist and break it, you would not really expect a fracture from that. So that would be defined as a fragility fracture. Now I say that, there's a few, really you need to know the whole exact story. So that's a little bit of a general idea there, but in general, that would be a fragility fracture. With that occurrence, that's a diagnosis of osteoporosis. You don't need the bone density test to diagnose that. But I said that's the way we prefer not to make the diagnosis, because the fracture is what we're trying to prevent in the first place. So we prefer to make the diagnosis before we have the fracture and prevent the fracture from occurring. So the second way is via the bone density test, or the DEXA test. Again, this T-score, here I've laid out the numbers. So osteoporosis, a T-score of less than or equal to -2.5, which means that you're 2.5 standard deviations below the healthy young adult bone density. So anyone who remembers any statistics, that's what that number means. But ultimately, a T-score less than 2.5, -2.5, is osteoporosis. I alluded earlier to osteopenia, or low bone mass. This is when the T-score is between -1.0 and -2.5. A T-score that's above -1 is normal bone density. So again, diagnosis with a T-score less than -2.5. So I talked about diagnosis, so that then begs the question, well, who should be tested? And that's a little bit of a tricky question, because unlike other diseases, osteoporosis is asymptomatic, meaning there's no symptoms. No one walks into the doctor's office and says, I feel my bones are getting weak, so I need this test. That doesn't happen. Any pain that sometimes people misinterpret arthritis pain, that could, that osteoarthritis and osteoporosis, sometimes the terms get confused, but osteoporosis is this asymptomatic disease until you have a fracture. But again, we're trying to prevent the fracture, so we want to find it before that. So we have to follow certain guidelines based on age and risk factors. So there's actually, luckily, several different committees and societies that have put out recommendations for who should be screened for osteoporosis. They're all very similar. I've put here the ones from the National Osteoporosis Foundation, or NOF. But in general, all females age 65 or greater should have a bone density test, or males greater than 70 should have a bone density test. And that's at least a one-time test to screen for osteoporosis. In addition to that, any patients younger than those age criteria can be tested if they're thought to be higher risk to develop osteoporosis based on certain risk factors. So, what are the risk factors? So the risk factors for osteoporosis there's several. These are in no particular order. None of these are necessarily more important than others, but estrogen is important for bone health. So early menopause in a female can increase the risk for osteoporosis. Average age for menopause in the United States is about age 51 to 52. So early menopause, whether it's that the ovaries stopped working on their own prior to that, or if the ovaries had to be removed surgically for any variety of reasons prior to that, puts the female at a higher risk for osteoporosis. Vitamin D deficiency, which can happen for a lot of reasons, and actually at our particular latitude here in Kansas, most people do not get enough vitamin D from the sun to maintain the normal level. So most people need, unless you're in the sun a lot, most people need actually supplemental vitamin D via just a pill. But patients that have certain gastrointestinal disorders such as celiac disease or Crohn's disease, where they may have even more problems absorbing vitamin D or calcium through the GI tract, may be at higher risk for osteoporosis as well. Low testosterone in a man, just the same as low estrogen in a female, or early menopause in a female, can weaken the bones. I alluded to some of these other hormones earlier, but overactive thyroid or overactive parathyroid can both weaken the bones. Hormonal therapy for certain conditions, and mainly these are breast cancer in a female or prostate cancer in a man. And the reason is because some of the treatments for those cancers are to block estrogen or testosterone respectively. And so it's easy to see why that could weaken the bones. Steroid medications, which can be used for any variety of reasons and include medications such as prednisone, dexamethasone, hydrocortisone, or it also includes steroid injections in the joints for arthritis. These can weaken the bones as well. And the last major class of risk factors are other medications, and probably the most common are seizure medications after the steroids for causing weakening of the bones. Okay, so that's all the risk factors. Hopefully I didn't scare anybody too bad with that, but I want to talk a little bit more in depth about treatment. We're not going to get into great detail here, but I wanted to give some overview of the options that we do have. And I brought back our schematic of the bone remodeling or bone turnover process, because this illustrates our two major classes of medications that we have to treat osteoporosis. So the first class that we have are called anti-resorptive agents, and these are medications that overall slow down the bone breakdown process. The cells called osteoclasts that break down bone. These medications in general, that's what they do, is slow that process down. Estrogen, raloxifene, which is an estrogen-like medication, it's interesting, it actually works as estrogen in some tissues, like bone, but it actually acts to block estrogen in other tissues, like breast. So this medication and another one that's like a sister medication of it are used in breast cancer sometimes because it blocks estrogen activity in the breast. Bisphosphonates are the most common medication used for osteoporosis. This includes medications such as the generic names alendronate, ibandronate, risedronate, zolendronate, or the trade names Fosamax, Boniva, Reclass. So these are ones you've probably heard before. Most common class. And then a little bit newer medication called denosumab or Prolia that works similar but a little bit different to the bisphosphonates. The other class of medications are the anabolic agents, and there's only one actually. It's called teriparatide or Forteo. This medication actually, rather than slowing down the bone breakdown, it actually stimulates the bone buildup. So we only have one in that class, Forteo. I'm not going to talk in great depth about all the different medications, but I wanted to illustrate that all of the medications that I've talked about have been proven in studies to increase bone density both in the spine and in the hip. And most of the medications have been proven in studies to decrease the risk for fractures. All of them have been shown to decrease fractures in the spine. and most of them in the hip and non-vertebral fractures such as the wrist. So the point is that we actually have a lot of good options for treatment of osteoporosis that they work. I said I wasn't going to go into a lot of detail on these, but there are, with the bisphosphonates, which again are the most common medications used, they include Fosamax, Boniva, Reclast. There's two sort of infamous side effects that are out there, sometimes getting some mention in the media. And so I wanted to just address those two and kind of put my 2 cents out there, hopefully to convince you that in general, these two things are not something to be overly concerned about, and for the most part are not a reason to not take these medications. The first is called osteonecrosis of the jaw. It's a jaw problem that can include any or all of pain, swelling, exposed bone, or fracture of the jaw. It happens most commonly in patients that don't have osteoporosis actually, but they have some form of cancer that has metastasized to the bone, and they're taking these bisphosphonate medications for that reason, not for osteoporosis actually. And they're taking high doses of intravenous or IV bisphosphonate. This is when this problem occurs more frequently. In patients taking bisphosphonates just for osteoporosis, the incidence or the occurrence of this problem is only 1 in 10,000 to 1 in 100,000 per year. So it's really pretty rare in patients taking these medications only for osteoporosis, okay? The thing that will increase the risk of this happening in that type of patient that's taking this only for osteoporosis is having oral surgery, okay? And I don't mean something simple like just a dental cleaning or a filling, but actually a tooth extraction or some form of an implant. And in that case, to decrease the risk of any problems, what we recommend is to stop the bisphosphonate medication for at least 2 months prior to the surgery, and then restarting the medication after everything is healed. So again, really low risk in patients that are taking this just for osteoporosis. The second one is something called atypical femur fractures, or sometimes called subtrochanteric hip fractures. Basically, these are stress fractures that occur in the hip in a location that's a little bit lower than we typically see hip fractures. It's thought to occur, if you remember I talked about this constant bone remodeling process going on, it's thought to occur because these medications slow down that bone remodeling process for a prolonged period of time in someone who's been on them for a prolonged period of time, to the point that it starts to impact the bone quality, not so much the bone density, but the bone quality. The risk of this disease, or this complication I should say, is about 3 to 50 in 100,000 per year. So again, maybe slightly more common than this one, but overall pretty rare still. And the shift in practice that's occurred because we've started to recognize this is in patients that have been on medication, on the bisphosphonate medications for several years, we start to think about doing what we call a drug holiday, meaning that if someone has been on the medication for 3 or 5 or 7 years, and their bone densities have been stable when we are monitoring those on a yearly basis, and they have not had any fracture problems, then we'll try going off the medication for a year or 2 and monitoring the bone density and making sure things don't go south in that regard. But we take a break from the medication for a year or 2, and we think that should decrease the risk for these problems. But overall, again, these are pretty rare, and we have a couple measures that we can take to try to prevent these problems from happening. So overall, I personally don't think that in general they're a reason to not take these medications. So sometimes I think things we hear about in the media, and sometimes it can sound scary, but these are the numbers, and the risk is really pretty low. So I just had to make that known, and my input on that. Anyway, I do have a quick illustration of that. So these top 2 are illustrations of a hip fracture in more common locations, and then this is that subtrochanteric or this atypical femur fracture, and then this is what it looks like in X-ray, which doesn't look good, but. Okay, so we've talked quite a bit about osteoporosis and diagnosis and treatment. And the treatment for osteoporosis, at least the decision to treat, is pretty cut and dry. For the most part, barring certain extenuating circumstances, if someone has diagnosed with osteoporosis, they should be on some form of treatment, and there's a few options, obviously. But what about osteopenia? Remember, this is that low bone mass that's not as severe as osteoporosis, but it's not normal either. This is a little bit trickier. Again, the T-score here is if it's between -1 and -2.5. So the decision to start treatment in this scenario is not quite as clear. Luckily, in the past several years, there's been the development of this new tool called FRAX, which helps us determine how high risk this particular patient is to have a fracture, and then help base our decision to start treatment or not on that. So let me show you what this looks like. It's just an internet tool, actually. We were able to put in some demographic information about a patient, and then some of their particular risk factors, and then their particular bone density. And then what it tells us is this box right here. It tells us their risk over the next 10 years for having any type of an osteoporotic fracture, or their risk over the next 10 years of having specifically a hip fracture. And they single hip fractures out because these are the most serious type of fracture to have. And then based on these risk numbers, we actually have some cutoffs as recommended by the World Health Organization to decide whether or not to start treatment. So I won't go in much more detail about that, but we actually have a good tool to help us make this decision now that we didn't have 5 or 10 years, well, probably 10 years ago for patients with osteopenia, but not osteoporosis. Okay, so we talked a lot about the different prescription treatments for osteoporosis, but what about some of the other things that we can do, and specifically calcium and vitamin D? In general, patients, everyone should be getting about 1,200 milligrams of calcium in their diet. That includes both dietary calcium that you get from dairy and whatever you may take over the counter in pill form. And to be able to kind of figure this out for yourself, a serving of dairy, which would be like a cup of milk, a cup of yogurt, a good amount of cheese with a meal, that's about 300 milligrams of calcium in general. So if you eat about 2 good servings of dairy a day, you need about another 600 milligrams of calcium in pill form to help make up the difference. Vitamin D, we talked briefly about this here in Kansas. Pretty prevalent that people are low on vitamin D unless they're taking a supplement. Most people probably should be on at least 800 to 1,000 international units a day of vitamin D. Most commonly that you can buy over the counter is called D3. Although I will say that I've seen a lot of patients that on this amount, it's not enough yet to get them normal, so you may actually need more than that. But that's actually a pretty simple blood test to check, and you know, that can be, the amount that you take can be increased. And so we won't go into much more detail about that, but these are pretty just general recommendations on what most people should be doing. In addition to that, regular weight-bearing exercise helps bones. So cardiovascular exercise, like doing an elliptical machine, is not actually going to do much for your bones, or water aerobics, not going to do much for your bones. The weight bearing helps stimulate the bones to form new connections and increase strength. So it's more like using, if you walk, carry some weights with you, or things like that to help increase the amount of weight bearing. Now, that has to be balanced against the risks of arthritis and putting more stress on the joints. So it's not always that easy, but that will help bone strength. Smoking cessation will help prevent osteoporosis or help improve bone health. Moderation of alcohol use, and then fall prevention. So sometimes if there's some balance training or physical therapy to help with certain weaknesses can help prevent falls, which if you fall less, you're going to be at less chance to have a fracture, even if your bone density is not changing, the same. So those are the additional things that we always like to recommend as well. That is the end of my presentation. I thank you all for your attention. I'd be happy to take any questions.